It's the day that marked the 55th batch of the NeuroManual therapy training, the signature course of the Academy of Orthopedic Manual Physical Therapists from Bangalore, the CNMT certification in NeuroManual therapy. This page, NeuroManual therapy itself, has so many followers and people who have seen the content here, which I have been sharing throughout ever since I am active on the Facebook. You can see that of late, recently, NMT is also provided as an online course, exclusively videos. At a basic level, everyone can take the course. The videos are lifetime access and you have extensive content exploring into the actual approach, how this approach is a patient-centered approach compared to the historically existing neurodynamics of Michael Shacklock, or even before that, the neural mobilization of David Butler. Of course, their works are commendable, and AOMPT takes its opportunity to in-depthly owe them the credit that they are responsible actually for the foundation of the knowledge behind the treatment of people with neuromusculoskeletal dysfunctions and neural pain. In the history and evolution of the NMT, I have discussed about what are my experiences, what are my thinking process, what made me to develop NMT as a separate clinical approach. But what we see here, when patient population, they come to us, is we try to evaluate them through interaction. We try to find out that how this neural symptoms which is there in the patients could be effectively managed using NMT. Remember that NMT is not a passive technique. NMT involves active forces. So you can use nerve sliders or nerve tensioners as active. You can also use in the neurodynamic offloading or loading positions motor control retraining, okay, and of course to further progression into balance or proprioceptive training. So remember that it's a comprehensive approach. Even in a patient who does not have a neural dysfunction, you can still use the NMT prophylactically. If you expect that the patient was having back pain and now having neck pain, you know that this is a ligamentous neck pain, or is it just the myofascial pain, but still cervical dura may be stressed because lumbar dura or low back already is vulnerable. The dura mater cannot adapt to the mechanical stress because lumbar spine kinematics are already altered because of earlier articular problem, if it was spondylosis, and cervical kinematics is altered because of the myofascial problem. Definitely dural may be functionally now subject is adapting but not having symptoms, but maybe could develop later. Okay, for such a patient, the safest would be to give a slider technique in the slump sliders. Prophylactic, it's not going to harm at all. Nobody is going to feel any kind of discomfort, okay, and absolutely perfect technique to enhance the dural gliding both with the periosteum of the canal, the spinal canal also, or with the arachnoid membrane, so both the levels. And dura mater has its own attachments to the intervertebral disc, it has attachments to the posterior longitudinal ligament, to the ligamentum flavum, so a lot of tissues which are there in the canal. Dura mater is also continuing as the epineurium of the peripheral, the nerve roots. Okay, the nerve root sleeves, they are formed by the dura mater. So that's absolutely fine. Any kind of movement, for example, it is like sliding techniques of the nerve are like mid-range movements. Okay, all of us which we do functionally, our neck movements in the mid-range, no one can contraindicate a neck movement in the mid-range. But the tensioner techniques are end-range movements. Okay, end-range movements. So end-range movements you have to take care, because end extension may not be permissible if there is a posterior column failure. End flexion may not be the indicated one if it's an anterior column failure. Okay, so remember that the end range techniques only you have to take care. So that's why tensioner techniques you need to take more precautions and more identifying more what is called as red flags and yellow flags. Whereas the sliding techniques you need not actually bother much about it. And with due application of reasoning behind the selection of the components, we can apply the slider techniques, influencing it from far away, the region that is far away from the region that is in symptom. So symptom may be here, you can use the left lower limb SLR. Okay, so still you can achieve that same sliding effect. Why I am telling you this is because in history taking primarily we are trying to find the red flags, the indicators or the contraindicators of what is called as when we should not use an NMT. Predominantly they range from the anthropometric characteristics, like for example age. Children below 7 years and above elderly below 70. Children below 7 is because of the differentiation. The connective tissue differentiation is not full, and you see that the epineurium to perineurium to endoneurium, okay, that differentiation is not there that much. Okay, it's still in the evolution process. And then next is even nerves anomalies can come if you are giving abnormal loads. The nerves may be more sensitive, okay, and they might change the course, okay, unnecessarily because of the abnormal mechanical loads. In children, usually we don't prefer even joint mobilizations, okay, accessory joint play techniques, because of hypermobility, because they develop the muscle tone and functionally they integrate the musculoskeletal system. There is no fixed age for that, but you see that after 8, 9, you can reassess, you can recheck, you can communicate probably better to them, know the tissue responses so that we can safely progress the techniques. Okay, so that's why age is one main factor. The next factor, of course, cognitive status, because as I am telling you that we need to communicate. NeuroManual therapy cannot be performed on a patient who is comatose, okay, in ICU, because what is the problem is you cannot know what nerve is in dysfunction, okay, unless there is which extent you have to actually give even if you are giving sliding techniques which is passive, okay, you still can't say whether it is effective or not effective. So we need to communicate with the subject. So unconscious or mentally retarded. Other spectrum of unconscious is medical emergencies. People who are having an unstable angina, okay, they are having severe chest pain and they want to take treatment. You will not go to them and say you are having your heart rate to be high, I will do sympathetic slump, okay, so that we can calm the sympathetic nervous system and parasympathetic activation can be brought back, okay. Although hypothetically this might sound to be okay, or mathematically may be okay, or logically may be okay, but practically you can't make the patient to sit in long sitting and do the thoracic movements and you give the rib mobilizations, okay. You can't even give a breathing exercise to the patient that time when they are having the angina pain, okay. And there the medical priority of giving the pharmacotherapy so that and go to the 12-lead ECG and or do an echo. So remember that the life-threatening situation. So that time you cannot go for a mechanical problem there. Okay, so that's the main reason All three categories will come together. And of course, when you are seeing for this red flags, okay, you know that there are general red flags for any kind of a manual therapy. But articular techniques may be contraindicated in patients who are having a hyperpyrexia, for example, or hypertension, if we say. Unstable. Okay, so the body temperature is not normal. It not only that now we suspect that it is COVID. Okay, mostly they do the temperature testing only. That could change because of many reasons to do with the scalp. Okay, but still it tells about the basal metabolic rate. Okay, what is of the individual. Okay, so if excessive inflammation, also systemic inflammation. Okay. And the homeostatic adaptation of the body is incapable. Okay, that's why the pyrexia is coming. So if you introduce any kind of a treatment, it is going to overload the body's homeostatic system. Okay, so the body is not at the best state to take any kind of a new treatment. So we have to find out the cause for the fever, and then we have to manage. Okay, same way hypertension also, unstable hypertension, similar to the cardiovascular diseases. So make sure that you don't miss this. And epileptic attacks. Why? Because they are also part of the neurological spectrum of presentation. In especially upper motor neuron disorders involving the brain and the spinal cord, where people, mostly with the brain, traumatic brain injury, okay, after that they will have epileptic seizures. The problem is it's a neural problem. You might think that, or you might convince the patient stating that, don't worry, I am using the upper limb or I am using the lower limb. It's not going to affect the brain, okay, all that. But after you have given that, by coincidence, if the patient throws seizures, definitely the patient and the near relatives and the caregivers will tell you that, or tell others that, the physical therapist gave some nerve technique and after that he got seizures. Okay. So that is something which is to do with the medical legal aspect. So better avoid, okay, in patients who are having history of epileptic attacks. You might ask a question like, for the last 3 months he has not got an epileptic attack, so can I use it? Even then, from my side, I will avoid it. Okay. And so those who are taking anticonvulsants or anticoagulants, okay, steroids. Remember, steroids are usually taken for any kind of inflammatory neuropathies. And all this goes into a picture where it's a collaborative reasoning, because physician, they prescribe the medications. You can't tell yes or no. Okay. You can use NMT or you cannot use NMT. What is the main thing is the collaborative patient, the physician and you. And the physician agrees that yes, okay, you are using some mechanical techniques which is similar to the joint movements and you are doing in combination, that's all. Okay, then it is fine. But if the physician tells that no, neural mobilization influences the brain also, because in stroke and hemiplegia, neural mobilization helps motor recovery. So it might harm the already short circuits and the hyperactive nuclei there, which is already sensitive, and we are using anticonvulsants for that. So then definitely physician word goes higher, because they are registered medical practitioners and they are medically liable. Okay, so make sure that it's a collaborative one. You can't negatively have a prejudice that NMT will not work also. Maybe some case reports come, some randomized control trials may come, okay, future might evolve, okay, and epilepsy also NMT is useful, okay. But as of now, the foundation knowledge indicates that safety is the priority, okay. But if the patient tells that you can use on me, you can use, okay, with the physician's consent. Okay, so always remember that. And when we talk about the rest of the history, musculoskeletal, yes, you just see whether the symptom is neural or combination where there is a neural symptom, or non-neural symptom. Try to identify that first. In the neural symptoms, typically tingling, numbness, distal region, pins and needles from the middle region to the distal region usually, and shooting pain, radicular symptoms, okay, traveling pain, usually proximal to middle to distal, okay, when it is peripheralizing. Of course, along the course of the nerve, definitely the symptom is going to be there. Whether it's only at one location, another location, like separate symptom regions, or it is a continuous symptom region. Okay. And then the next presentation, here itself it tells tingling and numbness is actually for the distal nerve fibers, free nerve endings and the nerve fibers. Pins and needles, nerve trunk. And shooting pain is for the nerve root. So different picture. Dura mater has extra segmental reference, that is, if C5-6 dura mater is affected till T4 I will have symptoms. Okay, that are widespread symptoms. Mechanical issues versus inflammatory issues are identified by constant symptoms and intermittent symptoms. If you are talking about a tingling and numbness being intermittent, sometimes the tingling numbness is there, some other times tingling numbness is not there. It becomes intermittent. And also, some activities worsens the tingling and numbness, okay, like texting or working on the computers, or writing, for example, and the other activities relieve the tingling and numbness. It may be playing sports, for example. So you have to think of intermittent nature, likely to be mechanical, then aggravating and relieving factors. What type of aggravating and relieving factors? Is it just the positions, or is it just the movements, or it's a functional activity? When it is positions, it can be vascular, because against the gravity and then towards the gravity. So arterial or venous. Okay, there's a coexisting one. So there you have to rule out the thermal regulation. You have to ask them the questions about cold water or a hot water shower, air conditioned room versus outdoor in the hot sun, how your symptoms of numbness is. Okay, you have to explore these questions because vascular. Of course, you go to the next picture where other than the positions is movements. In the movements, specific directions, because ulnar nerve posterior to the elbow. So if I flex the elbow, ulnar nerve is getting the tensile loading. At the same time, median nerve, which is anteriorly there, is getting compressed. Compression and tension both are kinetics. Okay, the forces on the nerve. Okay. So remember that we need to take care of this impact of the forces on the nerves. Okay. At the same time, median nerve is getting compressed when ulnar nerve is getting tensile load. Symptom in the thumb with the elbow flexion will not tell ulnar nerve just because flexion symptom is there. No, distribution. Okay. So there the next picture comes to where exactly the symptoms are. Innervation, whether it is sensory nerve pattern, the cutaneous pattern, sensory innervations, or is it the dermatomal pattern which is from nerve root or to the spinal cord segment, okay, or it is the peripheral nerve distribution, okay. So remember that if it is a dorsal ramus, it's a sensory distribution, only the low back, a band of pain from the lumbar spine horizontally. But if it's the nerve root, dermatomal will come. L2, 3, 4, multiple, then goes to femoral. Okay, only L2 means only the upper part of the thigh. Okay, anterolateral. And you see L2, 3, 4 femoral nerve skin cutaneous innervation is totally more distal. Okay, we go near the knee. Okay. So remember that different patterns are there. We need to see that whether it is cutaneous, whether it is dermatomal, whether it is peripheral nerve. Okay. Sensory free nerve endings innervation is a cutaneous one. Okay. And you see the next in terms of I was telling you about the median nerve and the ulnar nerve, thumb and the little finger, for example. Okay. Symptom in the little finger will indicate the ulnar nerve, whereas symptom in the thumb will indicate the median. Of course, there is again another exception because we need to know the applied anatomy. Adductor pollicis is supplied by ulnar nerve also. Okay, so it has a dual innervation as there. Okay, so remember that not just a symptom in the thumb. Okay, just to go narrow down into this. And the next part is associated motor symptoms. Other than the sensory is the motor. These are all the typical sensory symptoms, but there are atypical symptoms, neural symptoms, which are like ants crawling, worm going, okay, and pulling pain, okay, something like a steel wire which is getting pulled, okay, this kind of sensations. These are mostly common in neuromechanical dysfunctions rather than neuroinflammatory dysfunctions. It's like a muscle which is having an injury and it is having a spasm also will be affected with movements. Okay. At the same time, a muscle which is having a trigger point just by overuse also will be influenced by movements. So both are mechanical. But the underlying factor is trauma, inflammation. The same like that nerve injury, constant symptoms. Nerve injury and regeneration is there. So because of which muscle spasm can come. Okay. And the next picture is nerve adhesion, nerve friction. After friction, because specific ranges we are using the nerves, like how we are using the joints and the muscles. So the same, the friction creates that scarring, then adhesion, fibrosis. That creates the adhesion. So that actually is again a mechanical problem. Of course, the third category is the entrapment neuropathies, where you have compression of the nerve by other tissues like lunate, flexor retinaculum, the tendons of flexor digitorum profundus, okay, like carpal tunnel syndrome. So remember that this compression can be caused because nerve is enlarged, so the compression has come, or the space is narrowed, so the compression has come. Of course, we know that it's a median nerve symptom, it's carpal tunnel syndrome, but it's a syndrome. So what is the cause? Is the person pregnancy, if she is having pregnancy, or the adult who is having myxedema, metabolic disorders which have water retention in the body, it's a thyroid disorder. And you see that these patients develop carpal tunnel syndrome because the nerve actually enlarges. Neural edema, water retention within the peripheral nerve, okay, because of which it gets compressed. And the next is associated risk factors. That's what you have to see. If a patient with diabetes and having a neural symptom does not mean that it is diabetic neuropathy. Okay, we need to diagnose. The further investigation should be led by the history. Okay, diabetes diagnosis itself is a controversial thing. Okay, the sugar levels which are kept as the standards keep on changing every 10 years. Okay, so, and unless I get diagnosed, I am not a diabetic. Okay, but I am having a high blood glucose. Okay, so this is something subclinical presentations, impaired glucose tolerance, anybody will have. But before branding them into syndromes, that which is not in our domain, because that is the physician's domain. So think of whether it is mechanical, whether mechanical component is there. Even if mechanical component not there, continuous symptom is present. Even then, whether red flags are there, no. What are the other next precautions come after the red flags? Okay, which are the things which are like yellow flags? which will contraindicate tensioner, for example. Okay, those are the myelopathy, the spinal cord injuries. Okay, and you also see for we are using movements, we are influencing the joints, so there are local contraindications. So if you have a myelopathy, don't use the passive neck flexion, thoracic sympathetic slump, or the regular slump test, because it is in the canal. ULNT 1 or 2 is not going to influence much, unilateral. But if you do bilateral or contralateral, definitely it will influence the spinal cord. So that's why it is a very thin line of demarcation between an yellow and a red. Okay. Patients with the infections, if they have connective tissue infections, connective tissue disorders like SLE and scleroderma, polymyositis, any kind of connective tissue disorders, you can blindly tell. Perineurium, we don't know whether it is intact. Epineurium, it can rupture. Any kind of load. You are doing slider also. Okay. Still there is a friction and the fibers may be weak. Functional activity patient is doing, why they are not getting nerve injury? You might ask. So I will give a slider. The point is, slider is actually more of a therapeutic technique. It's not a functional technique. Functionally, when you mobilize, body will always be adapted because the brain has learnt that, it is programmed that functional activities right through from childhood. If you are talking about neurodegenerative disorders, not just the transverse myelitis, even multiple sclerosis, syringomyelia, for example, or you go to this. Anyway, when I told about myelopathy itself, you know that is the injury of the spinal cord. So that means everything that affects the spinal cord is going to be the same. Whether it is because of tumor and then spinal cords, whether it is because of vertebral body, multiple myeloma, okay, bone marrow, or it's going to be the epidural, extradural tumors, okay, hematomas, and also neurodegenerative disorders. Everything is calculated or is grouped under the same myelopathy. Okay. But you have a case report. I again and again reiterate the fact that there is a published case report. They used the slump test in a patient with myelopathy, patient improved. So there are a lot of things that can come. Where tension techniques only are contraindicated, I am telling. Okay. Sliding, I don't think it's a big contraindication for neurodegenerative disorders. Okay. Because tensile loads tissue may not be able to take, especially the neural plasticity is altered. Okay. People are not able to recognize the representation. Okay. The somatosensory cortex or the motor cortex is not able to actually coordinate, get the best voluntary activity itself. So if you are giving a therapeutic movements or mobilizations, whether the brain will be able to understand and memorize and retain, or whether it is going to recover or not. Even for stroke and cerebrovascular accident itself, neural mobilization was used by so many experts, randomized control trials are there. Nobody has explained the mechanism, how it is affecting that. Okay? How a peripheral technique is recovering the motor function. Okay? So that's the limitation of modern science. But why in a cerebrovascular accident it is beneficial, but not in a traumatic brain injury, or not yet explored, that's all. Okay? So don't think that it should not be done. Okay? If there is a mesothelioma, okay, like malignant tumors are there. So these kind of malignant situations, connective tissue malignancies, which can affect the meninges, meningiomas, benign, okay. So you have a situation where these can worsen or not worsen, but when you are using the technique and after that by chance the patient worsens because of any other reasons, you be better capable to answer that in the court, okay. So that is how you are getting the picture there, okay. So don't go by victimizing the patients, okay, and saying that I want to use something, I want to give something to the patient, I want to make them recover better, right? Correct. But will the patient understand the same? Will the physician accept the same? Okay? And how the system, the rules in your institution permits. Okay? Otherwise, there is nothing that can be going into reality. Okay? It will be a very sorry state of affairs. Okay? So that's why, even in a paraplegia, where there is sensations, nothing, motor, nothing in both the lower limbs, total transaction of the cord. Can't you do that neural mobilization for lower limb? Okay, you can do SLR. You can do, see that whether standing training or parallel bar with the orthosis, whether gait training, whether it will improve. Nobody has studied that till now. So you need to see that. Okay, to what extent you can progress and develop the evidence. Because they are making cats to actually transect, spinal cord transection cats, to just walk on the wheel. Okay, and the forelimbs and hind limbs are there. Forelimbs are intact, hind limbs are paralyzed. But still they walk with the forelimbs 10-15 steps. After that the hind limb also moves reciprocal. Complete transection of the spinal cord. And then it starts. This concept led to the partial body weight support treadmill training, where we can unload the body weight and make them to walk. And just by walking itself, central pattern generators, local levels like that. But nobody could locate where the central pattern generator, exactly in the spinal cord. Okay? So, functional training will always help the patients. Don't go by structural. NeuroManual therapy, that's why I am not insisting on peripheral nerves to go to their local treatments and position them and you do the movements. I am telling progression, muscle activation, change of positions. One is towards gravity, another is against gravity, another is in the side, elimination of the gravity. Integrating multiple tissues. Okay, so that's where we are coming to that picture of that functional translation. Okay. So, even an educational intervention has been shown to influence the brain. Of course, education should influence the brain, otherwise why are we learning? But this educational intervention has improved the SLR. So, pain neuroscience education. So, going for a descending inhibition. And then straight leg raise is improved 30 degrees in the study by the Lorimer Mosley, our expert in explained pain, which led to the greater motor imagery. Even mental visualizations also relieve to the neuropathic symptoms, not only neuropathic, even regular musculoskeletal symptoms, which are because of pain plasticity, central sensitization. Whether neural dynamics can influence, if you see, before 20 years, if you had searched on Google neurodynamics, it is only say neurotransmission within the brain. Okay? Nobody told tension test, nobody told nerve palpation or massage, nothing. Okay? 20 years only. It has been after Shacklock and they are doing it for 20 years. 1986 onwards it is going on, neural mobilization and neurodynamics. Still it did not come. Neurodynamics means people used to think only the brain dynamics, inside the brain the neurotransmission. Like how different nuclei, periactivital, grey matter, a lot of things you could talk. But point is, neurodynamics involves peripheral also dynamics. Okay? Then we are evolving. And unfortunately the two founders, you see that they did not come into clinical translation. Because that's the necessity why we developed the NMT itself. Okay? They are more of a technique-centered approaches. And we are selecting the patient for the technique there. Here, we want to combine the techniques so that we can do the best for the patient. So that's why we try to evaluate the patient's presentation using an extensive clinical history. Rule out. At the same time, then come to the indications. So you see for mechanical, whether it is influenced by touch, whether it is influenced by positions and movements, functional activities, So then you have a picture that yes, this patient might benefit from NMT. Okay. And then you take the 24-hour behavior, whether the symptoms are more in the morning, is it more in the evening? If it is evening, means after the overuse. If it is morning, means whether it is because of previous day's work, or is it because of abnormal posture in sleep in night. Every time they are waking up with numbness, thoracic outlet syndrome, okay, dead arm syndromes, okay. So get the correlation there. If the numbness comes after an aching pain, you should suspect myofascial. Okay, there is nothing wrong in suspecting that. Other tissues might be primary and neural can be secondary. Okay. A patient who is standing for a long time getting knee pain, after which feels pain in the leg down, you should be open to agree that it's a tibiofemoral osteoarthritis which has led to saphenous nerve irritation. So lateral aspect of the leg or medial, posteromedial aspect of the leg, okay, the short saphenous nerve distribution, symptom pain can come. This happens in anterior knee pain also. Patients who are having sitting for a long time and then they get up, theater sign. Okay, you might think that crepitus is there in the patella, so it is patellofemoral arthritis, right? But the infrapatellar branch of the saphenous nerve can go for an irritation at the ligamentum patellae medially. And after that, what will happen is you will have symptoms in the medial side. So, more distal, that is upper half of the tibia. Okay. So that's why whether testing is it part of the regular protocol or you want to do a in-depth evaluation dependent upon whether it is primarily neural symptoms or secondarily neural symptoms or it is non-neural symptoms. Okay. In a non-neural symptoms also you have to screen the neurodynamics. You have to do the tests. Okay, so that's the importance there. And in a trauma, in a patient with a history of trauma, if the trauma is a blunt injury, you are suspecting myofascial. If the trauma is a sharp injury, you can suspect direct nerve injuries like glass cut injuries. Okay, nerve injuries can come with soft tissue. And if the trauma is like weight falling or you fall down on the floor, combat sports, mixed martial arts, definitely that trauma will affect the ligaments, the capsules, okay, more. And if that is like in adolescent, then ligament injuries. In adults, it might cause a fracture. In elderly, again, it will be more incidence of fractures. Okay. So think of this associated factors interacting every time. Fall on the outstretched hand. Okay. It's not just a fracture alone or capsular strain or sprains, dislocations, wrist dislocation, but can also be a lunate dislocation which can lead to a carpal tunnel syndrome, or just because it was kept in the side and then the subject fell down, it might go for a neural strain. Okay. So you cannot say that unless you ask the subject what is the symptoms, okay, where you are feeling. If the patient is feeling sensory deficit in the thumb and patient is feeling weakness of the thumb, this is neural. Okay. Common peroneal nerve strain also, you see that there is a foot drop after an ankle sprain. Okay. You got a twist in the ankle, plantar flexion inversion, stepping down from the stairs, and you got a twist. After that, you are not able to dorsiflex the foot. Classical. Don't think that it is a ligament injury. Because of severe pain, I am not able to do. Pain is causing muscle inhibition, so it is. Come on, wake up. Okay. You have to identify that there is a neural component there. Okay. So that's why NMT involves a tunnel sign to palpation to neurodynamics, which is mid-range or end-range, sliders and tensioners. And you also go for the progressions of myofascial and articular together so that you do not miss. So remember, the pathomechanics can injure every nerve. If it is heel pain, it can be tibial or sural. It could be medial plantar or lateral plantar. Okay. Every nerve has its own pain patterns, and they can be independently involved or they can be involved together with the other tissues. Independently, what is the risk factor for a patient to have only a neural mechanosensitivity? Very rare. Okay, unless the nerves are vulnerable, like you have a vitamin B12 deficiency, definitely it will lead to neural. But still you see that these neural problems always and always, most of the times I have seen, what I have seen patients, everybody, they have a mixed picture. Okay, you have a combined picture of muscles being short with the neural symptoms, muscles being lengthened with the active trigger points and spasm and neural symptoms, both are there. And ligaments, again, strain and then neural symptoms. Even in functional instability of ankle, also common peroneal nerve strains. Okay. When you do the tensile sign on common peroneal, you do the palpation on common peroneal. You have a tenderness in the lateral ankle, but that tenderness changes with SLR. You know that it is a common peroneal nerve tenderness, it's not just the anterior talofibular ligament tenderness. Okay. So sensory and motor deficits, reflexes are all examined later. But if you see patients, you can ask these questions. To screen spinal cord injury, we commonly use the bladder, bowel, okay, balance issues, and bilateral symptoms, both upper limbs, both lower limbs symptoms are there. Definitely you should be alarmed that it could be a myelopathy. Okay. So get the extension of the history into subjective examination to identify aggravating and relieving factors, 24-hour behavior, and you see what is important next is the severity. Of course, we always ask how much is the severe pain and all that, but the irritability is the most important factor there, where I was explaining that the three factors that determine historical progression, okay, the region of symptom is multi-segmental. Okay, arm also, forearm also, symptoms are there. You need to know which symptom was first. First I was having symptom only in the arm, later I had symptom in the forearm. So you know arm symptom is more important. Okay, not the forearm. Okay. History in the progression of the disorder. Okay, and the next thing of course is the irritability. So arm symptom, it is pins and needles. Forearm, it is tingling and numbness. So which one is more bothersome? Which one is more persistent? Okay, when it is getting provoked means it's getting provoked on elevated position. That means after getting provoked, you take rest. Which one goes last? Okay, which one takes a longer time to go? That is highly irritable. That highly irritable symptom is the precaution. That is the area of focus where you should not load, you should offload. Okay. And the sequencing of neurodynamics, when you see that you can influence the nerve in the arm by moving the shoulder or moving the elbow. Okay, immediate influence. Next is of course wrist and neck. Okay, you can always influence. So you need to see that whether those regions are any contraindications. Okay, if I cannot use it, there is a burns in the arm. I cannot use the arm, I cannot use the shoulder and the elbow, and the bandage is there, correct? You can still use wrist and neck. Still it is a two-ended slider only, but this is called as an end-to-end slider. So you need to rule out for that neck that time. Okay, you need to ask questions like whether do you have neck pain, do you have any giddiness, okay? Do you have any weakness in the grip? Okay. So make sure that every part of the region can be influencing the nervous system. Okay. You can do a right ankle dorsiflexion and influence the left median nerve. Okay. If it is affected, definitely it will be responding to the ankle dorsiflexion, contralateral. Okay. Ipsilateral also, it depends on the extent of the dysfunction. Okay, remember that's why in patients who are totally immobilized, they are totally having contractures, they cannot move the upper limb at all, but they are having median nerve numbness, distribution median nerve. Okay, you can do the contralateral sliders okay, contralateral, and it will relieve the symptom here. Okay, so don't think that you cannot move the upper limb. How can I do NeuroManual therapy? Okay, movement is only the part of that kinematic one. You can do nerve massage. Okay, skin infections, skin lesions. Okay, you have open wounds. All this will create a modification. You have to use some other region. Even now, because of post-COVID, you might use the glove and then you will palpate the nerve. Okay? Hand sanitizer will reduce the sensation when you are palpating the nerve. But you should also know that nerve palpation is not just that location and then try to palpate the nerve. Once you have palpated, you are going to do this. Okay? And you know that there is movement under this finger, so that is the nerve. Because neck movements, why it should move in the arm? There is no muscle which is attached from cervical spine to the forearm. It's only the nerve. And it's a thread-like structure. So, you need to identify this. Okay, so extend seeing that if it was a tourniquet palsy, okay, patient went for donating blood or taking blood, for example, after that having neural symptoms. So, compression. Past history of fractures and after that having neural symptoms, you should know that it may be an entrapment neuropathy. But still, you cannot just jump into the conclusion until you clear out. Okay? What is exactly the pathomechanics? Whether it's the compression or it's the tension, is it just the adhesion, is it the nerve injury in itself, or it is like secondarily like systemic neural, like inflammatory neuropathies, metabolic neuropathies like diabetic, toxin-induced neuropathies are there. Okay, hereditary sensory motor neuropathy is also there. There are a lot of neuropathies. There is a wide spectrum of peripheral neuropathies where all the conditions in NeuroManual therapy is not yet studied. Okay, diabetic neuropathy itself, because of it was part of the PhD research. So ethical approval and then everything, it was fine, comprehensive environment, diabetes clinic, and it was Manipal University, so they permitted. In another region, you cannot expect that. Okay, so remember that it is to evolve further and further. That's why this extensive discussion will highlight that the role of history taking and extending into subjective examination, and how we plan for nerve massage, offloading to loading, and NeuroManual techniques incorporating primarily neural or associated myofascial and articular tissues techniques, or advanced into AMNMT. Okay, so opening the session for the questions for now, only for this session, history and subjective examination. Okay, so you can ask these questions now. Okay, and regular full about the NMT, including the morning demonstration through day demonstration for the posture and NMT, palpation and NMT, tunnel sign and NMT, or movement testing and NMT, active to passive to interface testing and NMT, and AM and MT as an extension of NMT, all of them. That interactive session will come on the main AOMPT Facebook page. Okay, so that I am going to begin now. After we close this session, we take a 5 minutes break, then I resume there. Okay, so now this session is open for questions, and we can see for history and subjective examination in NeuroManual therapy. Okay. We have CNMT participant, another is NMT practitioner, the other one is NMT workshop. Okay. See, the neurophysiological mechanisms are very poorly explored. Okay. The vague term is neural plasticity. Everything is plasticity. Okay. When I am talking to you, it's also plasticity. When I am seeing your comments, it is plasticity. Okay. I am answering those comments, that is plasticity. If I don't answer those comments, also plasticity. Okay. So everything is neural plasticity. So that's where the thing comes. Whether contralateral neuromanual therapy will influence the mirror neurons, okay, like how mirror therapy influences and how it helps in the motor recovery. Nobody has used it, nobody has studied it. Okay, even in the CNS lesions and using upper limb neural tension, neurodynamics treatments, nobody has explored using SPECT scan and PET scans, positive emission tomography, single photon emission computer tomography. Okay, so neural pathways don't keep asking this because nothing is going to happen there. Okay, in the brain, lot of pathways are there. Every pathway is so dynamic; it keeps on changing. Okay? It depends on our learning. Each and every person has their own neural pathways. Okay, so and vascular impairment is cerebrovascular diseases only. So where are you going to lead to? Okay, it's a dead end. Clear? You have to see the functional aspects. You have to see which are the activities that are limited for the patient, how those activities are mechanically related to the neurodynamic positions. Okay? And see which neurodynamic techniques could be incorporated. Okay? So far, the existing evidence has told that tension techniques have been used for upper motor neuron lesions, tension techniques of the extremity peripheral nerves. So slider techniques were not used. Okay, musculoskeletal disorders only we are using slider techniques. Raynaud's disease and now sciatica, which is relieved with exercise and warmth. Obviously, I told you that sliders are not at all contraindicated. So where are you thinking about? Okay, you can easily give. Peripheral nerves and vascular in diabetes. What does it mean? That is what I was telling, diabetic peripheral neuropathy. Okay, vascular is one of the hypotheses of the diabetic peripheral neuropathy. We have a lot of other hypotheses. Okay, so what is important is not the physiology; it's the functional activity. What is difficult for the subject, and that activity, it involves hip flexion, it involves hip extension. Then I see the related neurodynamics. Hip flexion means SLR, hip extension means prone knee bend or the saphenous. Okay, so think in that angle the mechanics into neurodynamics. Okay, and whether sliders could be given, whether contraindicated. Sliders are contraindicated means how is it possible? Okay, and if not in that region where it is affected, you can use the other remote regions. If it is contraindicated, otherwise also it should be epilepsy and other, Even in a diabetic neuropathy, a patient is having autonomic neuropathy, okay, together coexisting. It will have vasoconstriction, abnormal vasodilatations, and you will have ulcers, Charcot's joints, okay, deformities. That time you might think that if you are using tension techniques, it might harm the nerve. Still, for that also there is no evidence. Okay, so whatever you have to use carefully, and whatever you use in conjunction with communicating to the physician, because these kind of systemic disorders, always my answer will be the same. Okay, you ask 110 questions, my answer will be the only one answer, because all your questions are systemic disorders. So that means it will go to that only. Answer will be. Medico-legally you need to be protected. So make sure that that team comes in the picture, and then patient is also very well motivated. Then you use the sliders, and definitely if the patient improves and better, long term you have put, then publish it as a case report. Then after that further people will do a case series, and then interested people will do a randomized clinical trial, and after 10 years down the line in guidelines and all will come that traumatic spinal cord injury use NeuroManual therapy or neuromobilization. So that's where you are coming into the picture of establishing any evidence. Okay. Don't go by judgments. Okay. Is stretching painful? Okay. Lot of athletes enjoy doing the stretch. Okay, because they get pain, they are happy. They work out in the gym. Working out in the gym, is it very tiring? Tiring for the lazy people, okay? Tiring for the sedentary people. But the tiring sweat itself, the active people, they enjoy that, okay? So remember that. So it depends on that spectrum there. You can't tell tension technique is painful. Tension technique may be enjoyable by patients also. Okay, and it is like muscle stretch only. You are not going to vigorously do a ballistic stretch. Okay, remove the nerve, tongue comes out of the upper limb or lower limb. Okay, you are doing in terms of a graded oscillatory mobilization, and it is 1 to 4. It is all in the voluntary control of the patient. So there is absolutely fine. Okay, and you are not holding that position beyond 5 to 10 seconds. So you are not going to create a vascular compromise in the nerve, even with tension techniques. Okay, because the misnomer neural tension test was like nerve stretching. Okay, it came in that time, 1990s. So people misunderstood that, and they were maintaining the tension position for longer times. Okay, so then patients were worsening, and that led to the negative impact of neural mobilization will worsen the symptom. Okay, but that is what essentiated the neurodynamics of Shacklock, okay, where slider techniques evolved there. Once the sliders came into picture itself, it modified the dynamics totally. And when the contralateral and also utilization of remote areas came in the picture, absolutely everything is much safer. Okay, but which one to use? Clinically we have to see that, okay, where we have to. What is wrong with dopamine? Okay, we are not treating medications. Okay, we are treating the patient. And remember that whatever be it, the clinical condition or the medication, it is to do with the physician. Okay, so allow your brain to absorb that fact. Okay, the neural plasticity should be there to accept that fact that I have to discuss with the physician. Means yes, you have to discuss. Okay, so whether it is pyramidal or it is extrapyramidal, what is happening inside, who has studied there. Okay, even for our neuro-rehabilitation approaches itself, GOBAT or PNF, there is no evidence at all of effectiveness. But still neurologists, they encourage the physical therapists because their boundary is less. Okay, recovery cannot be brought by medication. They need functional training. So whatever approach you are using, you are telling aquatic therapy or you are telling treadmill training, you are telling orthotics, they'll tell no problem, try. Because there's nothing that has been mechanistically explored. Only one word is the neuroplasticity. That means what? Everything. Disorder is also neuroplasticity only. Treatment is also neuroplasticity only. You don't do anything and you are dying also neuroplasticity only. Until you are dead, neuroplasticity. Okay. Brain dead, then gone. That plasticity is gone. Understood? So neurodegenerative disorders alters the plasticity, but still there is plasticity. Okay, and remember that the learning will always come if the cognitive system is sound. Learning effect comes. The subjects can learn. Okay, whether a functional training of sitting balance training, we are doing a vestibular ball, a physio ball, for example. Can we do the slump test? Slump mobilization sliders so that the sitting balance improves. Absolutely, there is no study at all. Okay, that's the fact. So you need to accept that fact and rectify it. Okay, every question of yours is actually an idea for a research. Okay, there is no answers as of now that is existing. So sitting balance training you can give for Parkinson's disease, you can give for cerebral lesions, you can give for stroke or for traumatic brain injury or even cerebral palsy. Clear? So it does not matter where the condition is, what is the type of problem is. Our goal is functional. In that functional sitting, I have to give the therapy for training for sitting. That means in sitting, what are the things which are neurodynamically there? That is thoracic sympathetic and then the slump. Okay. So sympathetic slump and then regular slump, both are there. Sympathetic, is it indicated? I think that no, there is no autonomic disturbances. So okay, it's fine. If the patient is having autonomic disturbances, like for example Raynaud's disease, which you told, there was another question before, you can attempt the sympathetic slump. But when you are using that, will the safety issues will come? If you give a slider technique, there is absolutely no issue. But will the patient not complain tomorrow that because you have given, I am having extremely cold extremities night, okay? Evening you have given the slump sliders, and after that I am having both the extremities are totally cold. So that's where you have to see that. Okay, you can't defend yourself by telling that what I gave is nothing, it could not affected. Who will listen to you? There is no literature on that. Okay, so try to establish the literature for it before going into the other regions. Try to establish the rapport with the physician and try to get that cohesive decision making, not the coercive. Okay, don't coerce the patients into convinced and get them into treated. Okay, it should be a cohesive unit and then make the collective collaborative decisions. Okay, why? Because the safety, because 100 people will improve. Nobody will give the credit to the physio. You rightly pointed out. One patient worsens, all the blame will go to the physio only. So many players were getting injured. Okay, in Australia, our Indian cricketers. Every day there is an injury. Standing and they are turning, they are getting abdominal strain, it seems. Okay, Bumrah. With all these injuries, people are telling that, how injuries can come. This frequently, why injuries are coming. Never the Indian cricketers got this much of injuries. Why are they getting now? Maybe the physio. But when they are all playing again, they tell that it is a very good role of the coach. They are scoring higher. Technically they are sound. They can adapt to the different extremes of conditions. And they are still scoring. So coaches, the trainers are there. Bowling, batting coach, all of them. They are all getting appreciated. Physios only. Some of us are forwarding the messages where it is appreciating the physio. Okay. But if the physio is good, injury itself should not come. But still injuries come. Why? Because it's not just biological, it's psychosocial. People can have abnormal stress, mental stress, or the body is tired, but they don't tell that they are tired. Okay? They just keep continuing the training or the between match, the net sessions, for example. So you never know, okay? Because the player will be thinking that specific things in their mind, and it is when it is 5 people are there, somebody will be blamed, okay? And who will be blamed? The youngest one will be blamed. If they are all related to each other, younger one will be protected. Okay, it's a pet, like family. Youngest one you will be protecting them. But if they are strangers, the youngest one will always be blamed because the elder one is supposed to be brilliant. Okay? In that profession wise, if you are seeing trainers and coaches and everyone, physicians, sports medicine, physical therapist is the youngest. So physical therapist will be blamed. Okay? So same way like patients also, the symptom presentation also, some which are long standing symptoms, patients will feel that it's part of my life, it's normal. New symptom which has come, patient will be concerned about the new symptom. They are having severe pain right from the low back to the neck. They are not bothered. Last 3 years they are having this pain. They are not bothered. They are telling it's this kind of neck pain, back pain everybody has, so it must be normal. Now the numbness has come in the thumb for last 1 week. And they tell that I don't know why this numbness came, You are telling that no, there is a problem here, that's why here numbness. Patient will tell, I am concerned about this numbness, you treat the numbness, don't treat my neck or back. Okay? So you can always tell that it is, that's why communication is important. What kind of a personality you are discussing with, okay, the patient itself. Otherwise, why are we are only termed as physical therapists, but don't think that the physical is only the biological. Physical means psychosocial also is physical only. Okay. Sports person's recovery is quick if it's appropriate. Okay, they tell that they have recovered, even if they are 50% recovered. The sports persons tell that they are totally fit. Okay, that's the challenge there. Okay, and they try to show to the world that somehow that selection they have to get cleared and they have to be part of the main playing team. Okay, so because of that they'll tell that it is healed. Okay, I'm feeling better. Yeah, it's nice. They'll appreciate the therapist so that they'll get the clearance. Okay, that's why after that you do the tests, both general and also sports specific, and then you are screened for or cleared for the participation in the games. Okay. Right, so we stop here now. We have 10 minutes break and then we resume back at 6:30 at AOMPT's Facebook page for the question answers related to throughout the NeuroManual therapy, that is from the posture to the movements to palpations. Okay. Bye to all the CNMTs. And the people registered for the CNMT will be receiving the e-certificate today, immediately in your emails. I will announce in the group so that you can text me the details in the email. Those who wish to receive the hard copy, for the CNMT certificate only there is hard copy, not the NMT workshop certificate. Okay, so that is only e-certificate. But if you wish to receive the hard copy for the NMT workshop certificate also, get me the address in India and send me an extra fee, okay, for the dispatch and the courier charges. CNMT the fees includes the dispatch of the hard copy of the certificate. Okay, so you will be receiving it right at your home. So you have to provide the details in the email, and those who are first time enrolled in the CNMT, you have not sent me your photographs or something, please, I will give the instructions in the group so you can send it so that the certificate will have your photo and it will be a unique identity, okay, for you. So those who have completed the CNMT now are eligible that you can suffix CNMT after your name, and I congratulate all the participants for your really enthusiastic participation and wishing you the best of luck to keep upgrading yourself more and more and keep encouraging and inspiring the work of the academy. Okay, so good luck to you all. Really appreciate the active role played by the Vice President of the AOMPD, Dr. Pratima, and we also have members like Dr. Ritu and Dr. Vijay Lakshmi and Dr. Paramita, okay, who are always leading, they are leaders in learning. Okay. If we are the leaders in teaching, that means there are leaders in learning also. Okay, learning is the most important thing than teaching. Okay, so really pleasure to interact with you all, which helps to make the NMT approach itself get better for the future. Yeah. So good luck. I'll update in the group now and then I'll come live on the AOMPT Facebook page in another maybe 20 minutes. Okay, 6:40. Right.